Good afternoon and welcome. My name is Aida. On behalf of the Division of Healthcare Financing and Policy, I would like to call the meeting to order and verify that today's meeting agenda for the Public Option Design Session 3 was posted on December 29th, 2021 on dhhs.nv.gov and at notice.nv.gov. With that, I'd like to pass it on to Emma with Manat to go over some housekeeping items.
Live closed captioning will be available during today's meeting. You may click CC on the bottom of your Zoom window to enable or disable. There are a few ways attendees may participate today. First, participants may submit written comments and questions through the Q&A box, and all comments will be recorded and reviewed by the state. Participants may also submit comments and questions to nvpublicoption@dhhs.nv.gov. At designated times, spoken comment will be permitted. Participants must raise their hand for Zoom facilitators to unmute them and share comments. The facilitators will notify participants of appropriate times to volunteer feedback. If you logged on via phone only, press *9 on your phone to raise your hand, listen for your phone number, and if selected to share your comment, please ensure you are unmuted on your phone by pressing *6. If you logged on via the Zoom interface, press raise hand in the reactions area, and if selected to share your comment, you will receive a request to unmute. Please ensure you accept before speaking. Next slide. Public comment will be taken during the meeting at designated times. Individuals will be called on in the order in which their hands were raised and will be given 3 minutes. Please state your name and organizational affiliation when you begin. Participants are also encouraged to use the Q&A to ensure all feedback is captured, or again, you may email comments to nvpublicoption@dhhs.nv.gov. The state will publish a public option FAQ and will continue to use this resource to inform the public and address design questions. And with that, I'll pass it to Suzanne Bierman.
Great. Well, thank you all so much for joining us for design session number 3. Today, I'll quickly go over our agenda and talk about what we hope to cover today. Today, we're going to talk about the target population and affordability. Those are the key substantive issues that we hope to cover during this meeting. And we'll follow up with next steps and public comment opportunity. Next slide, please. Okay, here is the design session schedule. It provides an overview of the focus areas for the 6 design session meetings, along with the scheduled dates. Today's meeting is the 3rd design session, so we're halfway there, and we'll focus again on the target population and affordability issues. So I do want to flag here that the remaining 3 sessions will happen in January on the dates listed, the 13th, 18th, and 28th, and all of the topics listed in the focus area will be covered during those 3 dates, but did want to flag and highlight that the dates that particular topics may be taken up at the next 3 meetings may shift. So please do check the agendas, and the next slide deck should have those revisions incorporated. Next slide, please. Okay. Here we have some key public option coverage and design decisions that were incorporated in the text of SB 420 and determined by the legislature. So just wanted to take a little bit of time before we hop into the rest of our conversation today to go over what was laid out in SB 420 in a little bit of detail. So there was specificity in SB 420 about the type of product the public option will be, and it does specify that it must be individual health insurance that meets all federal and state standards for qualified health plans. So it is a QHP, a qualified health plan, and sold in the individual health insurance market. It must be offered through Nevada Health Link, the state's insurance exchange, and outside the Nevada Health Link to consumers in the individual market. Regarding cost coverage, carriers must offer 1 silver and 1 gold plan, which means that these products have to cover at least 70% and 80% of consumer healthcare costs annually. Next, premium reduction target requirements were outlined in SB 420 and wanted to go over a couple of those. So DHHS is responsible for ensuring that the public option plans meet these premium target goals, which is a 5% reduction each year or 15% over 4 years. And the targets for premiums apply for the first 4 years of operation and expire on January 1, 2030. Next slide, please. Okay, this slide too has additional provisions that were included in SB 420. So again, just going back over the legislation to identify what was already determined and decided when it comes to the public option design in the legislation from last session. And here, related to plan participation, there is a statewide procurement requirement that Medicaid managed care organizations are required to submit a good faith bid when they submit bids to participate in the state's managed care program. They also must participate in the public option. I wanted to flag that currently most Medicaid managed care organizations participate in Nevada Health Link, and in the future there will be there's a requirement in the current managed care organization contracts that they all participate in Nevada Health Link to try to promote continuity as consumers move from Medicaid managed care to the exchange. So I wanted to flag that that is already mostly the case and will be required in the future. The director of HHS must seek proposals from health carriers in a statewide procurement for the public option, and that will coincide with the next managed care procurement dates with a product launch date of January 1st, 2026. There are also requirements for provider participation outlined in SB 420. And providers that participate in the Public Employee Benefits Program, PEB, or Medicaid are required to enroll in at least one network for the public option. Additionally, the director has discretion to waive that requirement if necessary to ensure that PEB or Medicaid beneficiaries have sufficient access to services. Provider reimbursement requirements were also addressed and included in the text of SB 420. Rates were addressed, and in aggregate, those must be comparable to or better than Medicare rates generally. SB 420 also has exceptions for certain safety net providers that allow for higher rate floors than the general provision that we just went over for certain provider types like federally qualified health centers, rural health centers, and for those providers, those safety net providers, they can't be paid less than their cost-based rates in Medicare. And there's also a provision for certified community behavioral health centers, and they must receive at least the alternative payment methodology that they're currently receiving from Medicaid. I do want to highlight that this is not a cap on provider reimbursement rates, but instead is a floor to prevent rates from being lower than average Medicare rates in the public option networks. So providers will still have the ability to negotiate with health carriers for reimbursement rates in the public option like they do today. Next slide, please. Okay, so this slide outlines design elements that were not covered in SB 420. So they're not already specifically prescribed in law, but are important for the consideration of the design of the public option. So wanted to go over some of these topics, and these are areas where we would really like feedback from stakeholders. So again, this isn't the only opportunity for stakeholder feedback. We really want to encourage that in all of the design sessions, and also again, just want to flag that written comments will be accepted at any time through the public option email box that was outlined on slide 2. So with that reminder, I want to tee up some of the questions for consideration today. And so there's an optional provision in SB 420 that relates to the small group market. So some of the questions for consideration include, whether the state should consider in future years offering the public option to small employers in the small group market. Again, that's something we would really like feedback and input on. So please let us know your thoughts on that. Additionally, what considerations should the state give to the market and plans before pursuing the small group option? And should HHS recommend a separate stakeholder process and study of impact of a small group market addition to the public option, and questions around the type of new authority and funding that might be required for that. So I wanted to flag all of those considerations related to the small group market. Next, there are a number of open questions related to the public option procurement factors. Some of these were set forth in SB 420, but there are still open questions too around whether there should be new network adequacy requirements. We know access can be a challenge in Nevada, so something that we would appreciate feedback from everyone on is if we should have enhanced network adequacy requirements beyond the current state standards that apply to health insurance plans for the public option plans. How much alignment should we seek to encourage, as I mentioned before, between the managed care plan networks and public option networks to improve coordination of care and coverage as people's incomes and circumstances change to promote continuity of care? Whether the state should consider preference for plans that include additional benefits beyond the minimum that's required to be certified as a qualified health plan in their bids for the public option. So those are some of the questions that we would really appreciate feedback on related to procurement factors. And next, there is an opportunity for new federal funding, pass-through funding is one of the benefits of a 1332 waiver. So we're interested in thoughts around where the state should target that funding to improve consumer affordability and access to care, thoughts around whether good use of that would be consumer subsidies, provider rate increases, just open to ideas on the best target for that additional funding. Also any ideas on if the funding is limited, possibilities for supplementing the funds in the trust fund. So wanted to flag those there as questions that are open, and we welcome feedback and input on all of those. Next slide, please. Okay, this slide provides an overview of the goals again for today's population. I mentioned briefly before that we're here today to really talk a little bit in more depth about the target population and affordability, to really collect information around both of those considerations. So some of the specific questions on target population where we would like feedback and input include the specific population that should really be homed in on and kept top of mind as we design this this public option for the individual market. So there are a number of different subsets of the population that are identified here, including the marketplace eligible but currently uninsured, undocumented residents, or whether we want to focus on particular geography or age bands. Those are all open questions that we would appreciate feedback on. Additionally, whether there are things that we should consider in marketing new plans that may help with coverage challenges broadly. And as I mentioned before, the small group market question. So those are some of the questions that we've teed up related to kind of narrowing in and more specific focusing related to the target population. Moving on to affordability, some of the things that we're considering and would like to hear your thoughts on include how the state could use its current authority and discretion to generate those pass-through savings that we just talked about that are available through 1332 waivers to reinvest in affordability policies. SB 420 does talk about using those funds to help make coverage more affordable. So interested in more specific ideas on ways to accomplish that. What the goals for affordability should be, and which affordability policies might have the most significant impact on equity. As we know, there are challenges when we look at our population in terms of equity. So something that we want to keep top of mind as we design this public option product. Okay, next slide. And with all of this, I think I now am going to hand the next section of today's presentation over to Stacey Weeks with Aurora Health Group. So thanks, Stacey.
Suzanne. Hi, everyone. So like Suzanne said, we are going to talk a little bit today about the target population. There have been a lot of good questions about who is this public option targeted at. And just a little background first, before we dive into that, is thinking about looking historically at Nevada. Nevada, like many states after the ACA was passed, has made significant progress over the last 10 years. As you can see, its uninsured rate has gone down, but there's still struggles, as we know, in the marketplace. And despite progress, like we said, and we've said this before, that Nevada has one of the higher uninsured rates in the nation. Underinsurance is also an issue, and access in general, and some individuals still find premiums and cost sharing just to be unaffordable today, and therefore struggle to access healthcare. Next slide, please. So when we look at the demographic characteristics in Nevada, and Suzanne mentioned just now that looking at equity and disparities in the marketplace, these definitely come to mind as some of the more important statistics to look at. Although, for example, Latino Nevadans represent just 1/3 of Nevada's population today, they make up about 60% of the uninsured population. So it's something important to consider and to think about, is are there ways to design this product to really help meet that need and that issue today. When we look at geography, we do know there are access issues in different areas of the state, but when we look at uninsurance rates, there's comparable proportion of uninsured in both urban and rural counties. In absolute terms, though, the most uninsured Nevadans live today in Clark County. And like I mentioned, there are also a lot of workforce challenges, and that also has a play in terms of people being able to access healthcare and their health outcomes. So like Suzanne mentioned, are there ways to really market or promote the public option in the future to potential enrollees to help address some of these issues? Or are there other ways to design the product that can better meet their needs? Next slide, please. All right, so when we talk about the target population, we're really focusing in on narrowing down that eligible population that we know exists today is pretty large under the legislation, and really thinking about, is there a population within that eligible population to target the design of the product, and to keep that population at the top of mind while we were looking at the state is looking at all these considerations. And in thinking about that target population, the state can also think about how it wants to shape its affordability policies to help address some of the cost issues that they face today or other access issues. Some of the design decisions that you might want to think about, or the state can think about when it comes to actually identifying the target population, would be, are there things they want to do differently with the cost sharing design, for example? And that, when I'm talking in there more about the out-of-pocket costs, deductibles, or are there benefits in the marketplace today that do not exist today in the marketplace, or not enhanced enough that this population may need more from this product? And also looking at just network adequacy requirements, and looking at the geographic issues that we know exist, and then thinking going forward, thinking about also getting more value for consumers in the market for this population, and using those value-based provider payment design and models, and encouraging and promoting that through the statewide procurement. Next slide. All right. So this information, I think you guys have seen it, probably many of you, comes from the Gwen Center. It's back from 2019. It's like kind of a nice real breakdown of who are the uninsured today. And when we look at this population, we think about which segments of the uninsured could the public option help and should be targeted. The largest, as you look at this pie, the largest group is the eligible but unenrolled today. That's including Medicaid and the marketplace. There's also a significant proportion of the population that is ineligible due to immigration status. Are there things that the state can do with the public option, or in addition to the public option, to address these issues? Affordability challenges are also another area that are just in the marketplace today. Some of them, like the family glitch, may require a different solution than the public option, but there are some other issues for families and individuals who make too much today to qualify for subsidies in the market and could maybe potentially benefit from premium subsidies or even cost sharing subsidies to help lower their healthcare cost. Next slide. So this slide is a little bit of the same material, but I think it does lay it out a little differently for you to look at and to think about, how can the state think about these different populations and which ones can it target? Not only just the design of the public option, but also when you think about pass-through. So if the state does receive some federal pass-through fundings through its waiver application, are there areas that the state can also think about targeting that funding to help address some of these issues in the marketplace? For example, designing policies like premium subsidies that can be used off the exchange, or addressing some of those cost sharing issues on the exchange, or even some of those premium issues for folks that make too much today to qualify for subsidies on the exchange. I'm going to stop there and turn it over to Ann Carl in the interest of time from Annette. And next slide, please.
So on the next slide, we start to discuss a little bit more some of our questions around affordability. So we understand that promoting affordability is a core goal of the public option. And so the question is, what exactly does that mean, particularly in light of the target population, as Stacey was indicating? So one question would be whether there is, whether that should be focusing on premiums, whether that should be focusing on cost sharing, whether there are other affordability considerations that you have in place. And then there are also people who aren't eligible for any additional supports at this point, and whether they need something to sort of help offset their healthcare costs. As Stacey was mentioning previously, right, there are some groups like the individuals who are ineligible for premium tax credits or Medicaid because of immigration status. So on the next slide, we start to sort of get through what the pass-through savings that would be used to fund affordability policies. So obviously anything that increases premium tax credits or reduces cost sharing across, for a subset of the population would have an expense associated with it. And so the question is, how is that funded? The primary source of funding, the intention behind the public option, is to apply for a 1332 waiver that would generate federal pass-through funding. And we wanted to just highlight here that the pass-through savings impact, it sort of cuts both ways, what the public option would do. So first, the pass-through savings would be increased by the fact that the legislation requires that the premiums be reduced to below the benchmark plan premium. So that would then, for everyone who's receiving tax credits, lower the federal outlays for those tax credits. And that would be what generates the pass-through savings that then becomes the piggy bank that the state can use to fund its affordability initiatives. The flip side is, though, that to the extent that one of the public option actually attracts more people to enroll in coverage, that then increases federal outlays because you may have more people who are now receiving tax credits than there were previously. And so that's going to reduce your pass-through savings because pass-through savings are evaluated on an aggregate basis, not a per enrollee basis. So even if the federal government is spending less per enrollee, but they're spending more in aggregate, then that cuts into your pass-through savings. So that balance is going to be important to understand, and that will also affect how things are, the timelines for how things are phased in. But it also, again, just to give people a sense of what the potential magnitude of a piggy bank could be that we then could use for other affordability. So with that as context, I want to dig in a little bit more to talk about when we say affordable, what exactly do we mean? So next slide. This focuses on premiums. So for many people, they are eligible for premium tax credits. And on the next slide, we'll talk a little bit more about exactly who fits where. But again, so there's a group of people who they're eligible for premium tax credits, and those were increased. So the American Rescue Plan increased the amount of premium tax credits that are available and made individuals with incomes above 400% of the federal poverty level available for the first time. It used to be there was a cliff at 400%. So once you were over 400%, you received no tax credits. Now you do receive some tax credits. There are nationwide 13 million enrollees on the exchanges. There's an estimated 56% of them today are eligible for a $0 plan. So that means no premiums for more than half of exchange enrollees. 78% of enrollees are eligible for a plan costing less than $50 a month. So that is a result of the American Rescue Plan Act subsidies. So I think that the thinking is premium affordability may not be a significant issue at this point, but of course those subsidy increases are temporary. They last only through the 2022 plan year. They were included in the President's Build Back Better Act that is currently stalled in the Senate. Unclear exactly what that will look like, if it will be scaled back, whether the American Rescue Plan Act subsidies would remain as part of that scaled back and to the same magnitude. So lots of questions there, but assuming something similar to the American Rescue Plan Act were to remain in place, premiums perhaps are less of an affordability issue in this moment for that group that's sort of has a is eligible for significant subsidies in the exchange. The next slide just talks a little bit more to give a sense of what the continuum is. I'm not going to spend much time here, but folks will have this available for reference, and we're happy to, if people have questions and they want to put that in, we can also include that as part of our FAQ responses back. But this just shows what the continuum is. So there's a group of people, many Nevadans who 138% and below. Again, this is really focusing on childless adults. They would be eligible for Medicaid. There are some people, because of immigration status, who are not eligible for Medicaid. Then people are eligible, above that, are eligible for premium tax credits. You see it covers the 100 to 138, also shows you're eligible for premium tax credits for QHPs. That, again, there's a group of people for immigration status reasons who are eligible for tax credits because they're not eligible for Medicaid. You'll see that there's this cost sharing reductions. We'll talk about that in a second. That applies for the group from 100 to 250. Again, most of the people from 100 to 138 are in Medicaid, so it's not relevant to them, but there is a group of people who are eligible for that. And then employer-sponsored insurance, of course, you're eligible for that regardless of your income level, but it depends on whether or not your employer is offering that. So really what this is intended to show is it really is a patchwork, which again explains why there are some people who have fallen through the cracks and who don't have affordable coverage currently. So the next slide talks more about the cost sharing side. So there is additional support to help people with their cost sharing. And we lay out what it is here. So up to 150% of federal poverty level, the actuarial value of the Silver plan is 94%. So that means the plan covers 94% of the cost, and the individual is responsible for 6%. Now, 6% of the cost, that certainly is much more affordable than the standard Silver plan, which you can see all the way over on the right is 70%, where the consumer is responsible for 30% of the cost. So 94% is much more affordable than a 70% plan, but I do want to acknowledge that for people with incomes, just above the federal poverty level, even needing to cover 6% of the cost could be a significant barrier. So we don't want to undersell the fact that that cost sharing may still be a significant burden, even for people in that. Then you see as you move up the income ladder, your cost sharing reductions fall. So it's 87% from 150 to 200% of the FPL, and then it's only 73% from 200 to 250. So there, you're getting cost sharing reductions, but it really is quite minimal in terms of the difference compared to above 250%. So the state could use some of its pass-through funding to extend the cost sharing reductions to higher income levels. So, for example, to bring the 150 to 200 group up to 94%, or the 200 to 250, bring them to 87%, or some other actuarial value. The state would be responsible for funding those costs, and the state would look to be using those pass-through funds that we talked about as the source of funding. The next slide. So there are a couple of things to think about. So first is, are there ways to increase the pass-through funding? Again, the legislation sets out some mandated premium reductions of 15% over the 4 years that are set out in statute. And there's a question about whether that you could go beyond that. You know, interested in stakeholder reactions on that. I think, you know, at this point, I think that's viewed as sort of the primary goal, is that 15% reduction over the 4 years is where things are, but interested in reactions as to whether or not folks think that there's more potential there. Also, the state is exploring whether value-based care and purchasing opportunities can further reduce premiums, perhaps even beyond what is the mandated premium reductions. And then also thinking about, are there ways to strengthen the marketplace that would increase competition, that could drive down premiums, that would serve primarily to benefit the state by increasing the pass-through funding? Because again, as we've talked about, the tax credits cover a lot of the cost of the premium. So the primary benefit of driving down the premium is actually to increase pass-through funding, which then allows there to be more dollars to fund other things. And those other things could be like coverage for people who are ineligible otherwise because of immigration status. It could be to provide additional cost-sharing support. So those were some other things that we wanted some insight on from stakeholders, is should the state seek to reduce cost sharing for certain groups? If so, which groups? And then another question too about, is it more important to lower the cost sharing, so actually make the deductibles and co-pays lower, or is there also something really impactful that could be done by shifting what's subject to a deductible and what's not? So for example, or reducing cost sharing for not in aggregate, not affecting the actuarial value of a public option plan, but instead shifting and saying, look, we need to move certain, you know, behavioral health and primary care needs to have lower cost sharing than what we're seeing today in the market. So then other things like maybe on imaging or inpatient hospitalization, you would see go up, but we would try to make certain other elements more affordable. So I think really interested in others' perspectives on whether there are certain cost-sharing changes that could be useful to make coverage more affordable, even within the current actuarial values. So then I will just quickly touch on next steps before we open it up for public comment. The next slide. Again, we welcome additional comments, and please visit the public option webpage for regular updates. That's https://dhhs.nv.gov/public-option. You can submit questions or comments by writing to nbpublic-option@dhhs.nv.gov. And also, we would welcome you to attend the design session number 4, which is next week, next Thursday, January 13th from 1 to 2 p.m. Pacific time. That session is going to focus on value-based payment and cost containment, as well as rate setting and rate review, provider contracting, and networks. So with that, I will turn it over to Emma to facilitate our public comment.
Thanks, Anne. Looks like we have one hand raised at this time. Great, a couple more hands coming up. The first person I will call on is Helen Foley. Helen, you should be able to unmute now.
Yes, thank you. Good afternoon. I am Helen Foley, representing the Nevada Association of Health Plans. We will provide a letter next week from the association that addresses various questions that were proposed for this stakeholder meeting. But in the meantime, we wanted to give you a few highlights of some of our concerns and questions. The question proposed during this stakeholder meeting seems to have an underlying theme that if we expand networks and expand benefits, that it will result in lower premiums than comparable plans that are currently being offered. In reality, if you expand networks and expand benefits, more than likely, premiums will be increased. The association believes that existing state network adequacy requirements are already in place in Nevada, and we should apply that to the public option plan. The existing network adequacy determination process includes a network adequacy council with diverse representation of insurers, providers, and public members. The council holds multiple public meetings each year and makes recommendations to the insurance commissioner. It's working pretty well, and we think that should be the standard for public option plans. Additionally, the discussion on expanding networks of providers in a market already strained by the significant provider shortage could potentially lead insurers to simply not be able to meet those standards. And there were questions about the small group and targeted population. The association does not believe that a small group public option is necessary. Currently, there are various options for small groups in Nevada that include association plans, stop-loss plans, and the ACA plans. It's important to note that many of the uninsured in Nevada have coverage options already available through Medicaid and subsidized exchange coverage. For example, in the proposals that you were showing and the graphs, 37% of the uninsured are already eligible for Medicaid, and yet they are not enrolled. A focus should be on enrolling those that are uninsured with coverage options that already exist. And again, the paramount question is, who is your target market? Who are the people who are uninsured that cannot find coverage either through Medicaid, Medicare, the exchange, or private insurance that you want to cover? As raised during the previous meeting, it remains important to understand the fundamental structure of the plan design prior to moving forward. Senate Bill 420 is ambiguous on whether the public option program is intended to be fully insured products offered by an insurance carrier or a plan designed and administered by the state of Nevada. We remain steadfast in our opinion that the lack of clarity and direction in the bill warrants the need for an actuarial analysis that evaluates both a fully insured and a self-funded plan design. Additionally, we share the opinion raised by various stakeholders at the previous meeting that an actuarial analysis should be completed prior to requesting such detail about the plan design to understand the market impact and ensure unintended consequences do not materialize from an uninformed implementation. We appreciate the opportunity to provide comments at these meetings, and we look forward to a time when there is more interaction among all of us in order to formulate something that will be workable and beneficial to Nevada and its citizens. Again, we will share some written comments in the coming week, and we thank you so much for your time.
Thank you for your comment. I'd like to call on Martin Fitzgerald. Martin, you should be able to unmute now.
Hello, my name is Martin Fitzgerald, and I'm here on behalf of New Day, Nevada. I appreciate this discussion on target populations and cost sharing. While not considered the most interesting part of the healthcare discussion, I think these essential elements in design are essential elements in designing a successful public option and producing a product that Nevada consumers want. First, when thinking about target populations, I believe it is critical to include small businesses and their employees in this discussion. While there may be opportunities to explore how we incorporate a public option in the small group market, I also think that the state should explore how it utilizes the individual market in conjunction with small businesses. For example, exploring if there is a way to allow businesses with 50 or fewer employees to access a state-based premium support funded by the Public Option Trust Fund for their employees to use on the individual market. This has the benefit of lowering the overall cost of healthcare for small businesses without forcing them to endure brokers or the somewhat more complicated process of securing small group market insurance. This might be an out-year discussion, as the state would have to build up and get federal approval for the dollars that would flow into the Public Option Trust Fund. However, I believe this is an excellent time to think about and set up that structure if it is feasible. On that note, I think it makes sense for the state to hold off spending dollars from the Public Option Trust Fund immediately. This would have the benefit of allowing the state to build up a more robust trust fund while analyzing how the public option can more adequately provide support to capture the targeted populations like small businesses and the additional ones I'm about to mention. Patience here is a virtue. In addition to the small business market, that small businesses and their employees that I talked about, I think the target populations that the public options focus on are the ones that are currently falling through the gaps of the current system. Specifically, Nevadans over 50 who are transitioning away from full-time employment but are too young for Medicare and current insurance products are too expensive for their budget. By creating and providing a robust and affordable public option, we can capture these Nevadans that think they are healthy enough to forego healthcare for a few years and then find themselves in the ER with deteriorating health situation because they've been skipping their primary care appointments, hoping to make it until they get Medicare. Secondly, I think Nevadans who are currently unable to access insurance on the marketplace and who need a product available off market to ensure that they can get insured. Finally, I think Nevada families that currently struggle to afford the full freight of healthcare premiums on the marketplace, but who have family incomes above the federal premium support level where federal premium supports kick in. I think these three constituency groups, as well as small businesses, should be the core focus of the public option. In addition to these targeted populations, the public option should allow the state to think about how it can improve access and affordability to mental and behavioral health care. Nevada has struggled with providing behavioral mental health care for years in both the private and public insurance. We need to think about how we adjust cost sharing so that mental and behavioral health care is more affordable and provide help to the countless Nevadans that have struggled with mental and substance abuse issues, especially during the pandemic. This is a real opportunity for the public option to provide a solution that Nevada families desperately need. A final thought is that I think the state should use the rollout of the public option to improve its outreach to the uninsured population. Just as the rollout of the ACA informed Nevadans about the coverage provided by Medicaid, and in some instances Medicare, the marketing of the public option can be used to inform Nevadans about the opportunities for coverage under Medicaid and the public option. This is an opportunity to fill in gaps of the uninsured market that are eligible for Medicaid but blind on how to access these benefits. I appreciate your time and your work on the public option. Thank you.
Thank you for your comment. Next, I'll call on Barry Gold. Barry, you should be able to unmute now.
Yeah, thank you. This is Barry Gold. I'm the Director of Government Relations for AARP Nevada. When you're looking at the target population, I think there are certain ones that certainly seem the best to eye and have the most people there and easier to capture. However, I want to ask you to please not ignore the 50 to 64-year-olds. The 50 to 64-year-olds utilize healthcare more often, understand the need for insurance, and will end up being one of the buyers of this insurance. When Nevada HealthLink first was designed and offered to the marketplace, what they did, the target population for all of the marketing was aimed at what at the time we called the young invincibles. And all the marketing showed 20-year-olds falling off of falling off of mountain bikes, okay, and why they would need this kind of thing. It took me a few years to convince them to start marketing to the older adults, the 50 to 64-year-old. And I believe at one of the last meetings, I believe they said that the 50 to 64-year-olds comprise about 1/3 of the marketplace for Nevada HealthLink. So please consider the older adults who have a need for insurance as much or more than everyone and are more likely to buy that. When you talk about cost sharing versus premiums, I think that's quite a delicate balance. And I think you need to be careful because low premiums bring people through the door, but cost sharing drives them back out. So if you have these low premiums, you will get people to buy the insurance, but then when they start using it, I believe they used to call that junk insurance. Junk insurance was stuff that's cheap to buy, but nobody will use. And so they'll buy it for a year and then they'll bail out of it and we'll have this churn. So that is quite a delicate balance. And I don't have an answer for that, but you need to look at kind of both, because if you just shoot for premiums, when people start to use it, they're going to say, it's just not going to work for me. Thank you for your time and for listening to the comments. And yes, on behalf of the 345,000 AARP members across the state, we appreciate you considering the public option as a way to increase access to affordable quality healthcare. Thank you.
Thank you for your comment. Next, I will call on Patrick Kelly. Patrick, you should be able to unmute now.
Good afternoon. My name is Patrick Kelly. I'm the CEO of the Nevada Hospital Association. Today, I'd like to address the question, what specific population should the public option target? The short answer is Nevada's uninsured. Enlarging this target population beyond the uninsured may disrupt the state's insurance market and its healthcare market. The public option legislation requires premiums to be 5% less than commercial insurance. We believe that a 5% price differential would be very disruptive in the insurance marketplace. Who wouldn't want to save 5% on their premiums? If the target population is expanded beyond those who have no other options, individuals and small businesses will drop their existing commercial insurance and move to the public option program to save money. This will be extremely disruptive to the insurance market. Movement out of the commercial insurance market will drastically disrupt the healthcare sector. For hospitals, the impact will be great. Medicare and Medicaid payments to hospitals don't cover the actual cost of providing services. So who makes up the difference between what Medicare and Medicaid pays and the actual cost? Commercial insurance. The cost from Medicare and Medicaid are shifted to union workers, small businesses, and anyone with commercial insurance. This shift will become greater with the public option unless the target population is limited to those who cannot obtain health care coverage, where the public option reimburses hospitals at a cost plus level. The public option will likely pay hospitals at or near Medicare rates, which once again are below the cost of providing the service. This means even more costs will be shifted to people with commercial insurance. If more people leave the commercial market for the public option, the problem snowballs. At some point, no one will be able to afford commercial insurance. You may think, well, good, everyone can join the public option and pay less. Well, here's the problem. We already have a fragile healthcare delivery system in this state, and access is poor. Hospitals will be unable to invest in new facilities and update equipment. Other impacts will be felt as well. For example, access to physicians could be adversely affected. Hospitals employ a significant number of physicians. Physicians want a steady source of income to practice in Nevada. Hospitals will be unable to employ physicians if the commercial market falters. Physician access will be worse than it is now. Nevada has an acute shortage of nurses. These professionals are commanding top dollar. Who will cover that expense? Medicare and Medicaid payments are barely increasing. If we don't have nurses, hospital units will shut down because they can't be staffed. Access will decrease. In summary, opening the public option to more than the uninsured is just a bad idea. Thank you for listening.
Thank you for your comment. I will now call on Natasha Mclan. Natasha, you should be able to unmute now.
Thank you. Hi, my name is Natasha Mclan. I am a medical student and lifelong Nevadan. I'm currently residing in Reno, Nevada, and I'm attending the University of Reno, Nevada School of Medicine, pursuing my MD degree. Thank you for the opportunity to weigh in on the benefits of Nevada's public option today. As a medical student, I'm grateful for the public option and its potential to expand healthcare access to more Nevadans. In my experience, the most common barriers to healthcare for people are affordability and availability. By now, we're all familiar with the grim data on how healthcare costs keep going up with no end in sight. And for many of us, especially in the healthcare field, what is egregious is the fact that insurance companies and drug manufacturers continue to rake in tens of billions of dollars in profits at a time when the COVID-19 pandemic has devastated countless lives and critically hampered our employer-based and private healthcare infrastructure. Even as fewer people are actually seeking and getting medical care, yet still paying their same insurance premiums. Over the past decade, health insurance premiums for employers and individuals have gone up at a faster rate than workers' wages by double digits and more than doubled the rate of inflation. In real terms, families simply cannot afford to get healthcare under the status quo. I've seen patient after patient forgo needed medical care due to cost and access issues, regardless of whether they had insurance or not, and regardless of what commercial plan they were on. So I encourage you to expand the public option beyond just the uninsured to consider those who are underinsured as well. Just this morning, I rounded on a patient who is insured. However, due to the paucity of care that her insurance provides for, she's had multiple hospitalizations for worsening chronic conditions due to an inability to access preventative care. Besides being a huge inconvenience to her, it costs our hospital systems and state a lot more money to provide care in this way. By maximizing, scaling back the cost of premiums and reducing what my patients pay by 15% over 4 years, the Nevada public option will help make insurance care more affordable for people and hold insurance companies more accountable. Nevada's public option could also help businesses better afford healthcare so their employees are healthier and more productive. Requiring reimbursement rates at or better than Medicare reimbursement rates, as Nevada's public option does and should continue to do, will help make hospitals and healthcare facilities sustainable, especially in rural and underserved regions where uncompensated or undercompensated care threatens hospital margins. Nevada's public option is especially beneficial to rural and underserved Nevadans who live in counties where health insurance options are extremely limited. Under the public option, every resident should have access to at least one high-quality plan. And from an affordability and access perspective, Nevada's public option can help close gaps in healthcare, reduce inequities, and improve the health and well-being of Nevadans. So thank you for your work to make healthcare available and affordable to all of our fellow Nevadans, and thank you for the opportunity to speak today.
Thank you for your comment. Next, I'll call on Stacey Sasso. Stacey, you should be able to unmute now. Stacey, can we go ahead? I hear you now.
Good afternoon. My name is Stacey Sasso, Executive Director for the Health Services Coalition, representing 25 employer and union-sponsored health plans in Southern Nevada. As we've previously stated in other meetings, the coalition remains concerned about the overall impact of the public option and healthcare in the state. The coalition is still working with a consultant to assist us in compiling all the information needed to better understand the impact of the public option to the plans we represent. But we are still in review stages with him. We appreciate the stakeholder meetings being held and would like to find a way to possibly present our consultant's impact report when it's ready in the upcoming weeks. Again, thank you for the opportunity to work together on this.
Thank you for your comment. And next, Benjamin Shalinor. You should be able to unmute now.
Good afternoon. My name is Benjamin Challoner, Policy Director for Faith in Action Nevada. I'd like to thank you all for the opportunity to provide public comments to the process of implementation of a public option as authorized by Senate Bill 420. In addition to echoing the statements provided by Martin Fitzgerald, I would like to reiterate the need to target our Latino, Latinx population. The majority of Nevada's uninsured and underinsured population, as presented in the earlier today, are Latino, Latinx, while only making up about 30% of the population. Undocumented Nevadans also make up a portion of the uninsured and underinsured. And it's critical that we continue to focus on these target populations who often don't have another option available to them or don't understand what may be available to them currently. Many times there are barriers that keep these folks from actually being able to sign up for these plans, barriers such as language access, as well as lack of cultural competency and outreach. One thing that is often ignored when it comes to cost is the intersectionality of it. We are currently experiencing an all-time high in rental and housing cost, as well as a rising cost of childcare in our state. That's on top of the rising cost of nearly everything else that we are currently experiencing. It is crucial that we are able to provide an affordable public option, both in premiums as well as cost sharing, so that Nevadan families don't have to make difficult choices when it comes to being able to afford healthcare and other aspects within their budget. Thank you for your time, and we look forward to the continued community meetings.
Thank you for your comment. At this time, I don't see any other hands raised. I think we are able to close the public comment period.
Thank you for joining.